Everyone, my name is Rabia Ghazi and I'm the Movement Disorder Fellow in the Department of Neurology. Today, I have a case of a 66-year-old male who presented with progressive abnormal involuntary movements that started in his 20s as muscle twitching that gradually evolved into high amplitude sudden jerks of the legs and arms. And in his 40s, the movements became much regular and disabling to the point that it's affecting his eating, drinking, writing. He also developed neck and truncal pulling to the left side that was painful for him. The only thing that seems to help calm these movements was alcohol, but luckily he was not a heavy drinker. And he also tried a number of medications, including Keppra and clonazepam, that seemed to help him with the jerky movements. And eventually, because of the muscle pulling in the neck, he was given botulinum injections, and that seemed to help with that problem also. And something important in the history was that he had severe COPD and a 30-pack-year history. Important aspect was that he had a strong family history of similar abnormal movements in his sister, daughter, and a paternal grandmother. His sister actually ended up getting a DBS for the similar kind of abnormal movements, but she did not improve significantly, unfortunately. I have a video of the patient, but I just want everybody to keep in mind that this is the patient who is presenting to clinic, who's already being treated and responsive to the medical treatment. So as I play the video, I'm sorry about that. Something happened. So okay, so as we go through the video, I would like to mention.
Just go back into the other mode. Yeah, play it right from this image. There you go.
Okay, sure. So as you can see that he has a little bit of jerky movements in his head, and that become a little more prominent when he closes his eyes and tend to concentrate. And also we noted the brief jerky movements in his upper extremities, proximally more than distally. And there is some head tilting to the left side, some left sagittal shift, as you can see, and there is a slight to mild tilt of the trunk to the left side as well. That becomes more prominent as he starts walking. On the repetitive hand movements, he does seem to have a little bit of irregularity, but not any size decrement that is suggestive of bradykinesia or Parkinsonism. And for most part, when he walks, the dystonia is obvious in the neck and the trunk, and also there is some sudden brief jerky myoclonic movements, as you can see. So basically, based on his exam, we diagnosed him with myoclonus dystonia. Since he had a strong family history and the myoclonus was responsive to alcohol, it was suggested that he could have sarcoglycan epsilon mutation, and on subsequent testing, he was found to be positive. We continued clonazepam and Keppra as well as botulinum injections, as these seemed to help. And although we could consider DBS, but it was not recommended because of his severe COPD and high risk from the anesthesia. I just want to share a few slides regarding myoclonus dystonia, which is a syndrome characterized by myoclonus and dystonia, as the name suggests. And typically in these patients, the dystonia is less severe or mild and involves either the neck or the limbs. And myoclonus is responsive to alcohol. The age of onset is usually in the childhood, but there are case reports of presentation of the patient starting symptom later in their life. In childhood, the girls tend to present earlier than the boys, and usually the disease is progressive for several years before it tends to plateau. And there is like a large population of these patients who develop psychiatric problems, including phobias, alcohol dependence, anxiety, and depression. In most cases, there is little or no functional disability, but we do see a lot of patients in clinic who actually have significant disability from these abnormal movements and end up getting DBS. Genetics, it's genetically heterogeneous, but the most frequent mutation is the epsilon sarcoglycan mutation, which is autosomal dominant inheritance. But there is variable penetrance in expression, especially due to the phenomena of maternal imprinting. There can be reduced penetration 5 to 10% compared to up to 90% if it is paternally inherited, and that is reflected in our case also, where we see that although the patient probably inherited it from his father, but the father was not symptomatic, although there was a strong family history in the paternal grandmother and also in his sister. There are several other mutations that have been identified and have been reported to have the similar clinical presentation. And so far, epsilon sarcoglycan, which is expressed heavily in the brain and some other tissues, we don't know exactly what is their mechanism of action and how they are affected in myoclonus dystonia. As we can see in our patient, benzodiazepine and anticholinergics, and there are several other medications, anti-epileptics, that have been tried and been reported to be effective. But most recently, there have been case reports of tetrabenazine, the VPAT2 inhibitor, has been found to be showing promising results in myoclonus dystonia patient. There's only one double-blind crossover control study on zonisamide that showed significant benefit in these patients. And botulinum injection is also a good symptomatic treatment. Surgical treatment is actually quite effective and well tolerated. And the improvement is like similar to what we see in primary dystonia. It could be up to 60% and expected in like 12 months of after the surgery. And there have been literature review of comparing GPI DBS versus the VIN. Although the efficacy was similar in the results we see for myoclonus, but dystonia definitely responds better to the GPI DBS. And like other primary dystonias, the younger the patient at the time of the surgery and the shorter the disease duration, that seem to improve the results from the DBS. There's some just key points to remember in diagnosing these patients and treating these patients, and considering that DBS is definitely an option in moderate to severely affected patients, especially who are medication refractory. And these are my references.
All right, thank you very much. They're very interesting and concise, right on time case. So Brian, I'll throw it to you to introduce our speaker today.
Thanks very much, Rich. So it's a real privilege and a pleasure for me to be able to introduce an amazing scientist and a very close friend, Dr. Matthew Schrag, for Grand Rounds this morning. Matthew is quite an impressive person. He did his MD and PhD in Loma Linda, and he managed to accomplish both of those things in a total of 5 years, which is extremely impressive. He went on to do his residency at Yale and was awarded Resident of the Year twice, both in his second and fourth years of residency. And then he was recruited to Vanderbilt, where he started off as a fellow in vascular neurology and ended up staying on as a faculty there, where he's been extremely productive. He's founded the Cerebral Microvascular Diseases Clinic, as well as the Vanderbilt Brain Biospecimen Bank at Vanderbilt. His funded work examines lysosomal dysfunction and its relationship to Alzheimer's pathology, as well as mechanisms of vessel fragility in amyloidangiopathy. He's also a very multi-talented person. In addition to his more translational work, he's also published several seminal papers on the treatment of central retinal artery occlusion. Some of his papers really ignited interest in the field in this condition. One of his papers was actually a systematic review and meta-analysis of TPA for CRAO, which is motivated by a case he saw as a resident. This paper, he ended up getting it published in JAMA Neurology. It was a very, very influential paper, and he actually did it all when he was on night float as a PGY3, which is extremely impressive. This is all in addition to a further portfolio of work concerning clinical management of ICH. He's got numerous grants from the NIH, including a Paul Beeson Emerging Leaders Award from the NIA, and then 2 R series grants, and he also had some very exciting news earlier on in the week on that front. His talk this morning is entitled Microvascular Degeneration in CAA and Alzheimer's Disease. So Matthew, I'll turn it over to you.
Thanks, Brian. That's very, very generous of you. I think that you should come every time I give a talk and give the introduction. That was great.
That could be arranged.
No, I'm very, very excited to be here with you guys and talk about this topic. I'll tell you, a lot of my productivity has come because of Brian's productivity. I think tag teaming projects has been a real pleasure over the last couple of years. I've learned an awful lot from Brian about central retinal artery occlusion, and I feel like I talk about that more than most topics. And when we're not talking about that, we're talking about lysosomes and Alzheimer's disease. So we rarely get around to today's topic. And so I'm very excited to be giving this talk. It's more or less a new talk. And so I'm looking forward to getting feedback on this. And at least the last half or so is not published. And you'll see that some of the data is not fully cooked yet. But it's I think we're onto some interesting threads on this topic. I'll be very curious to see what you all think. I've probably brought a little bit too much material, so forgive me if I skip over a couple of the less interesting parts, and we'll focus on hopefully the pieces that are of greater interest. But I really like this topic for a couple of reasons. One is because both Alzheimer's disease and broadly stroke are top 10 killers of Americans. And there is this zone of overlap between these two classes of diseases that's a really important phenomenon. We think about Alzheimer's disease and we think about vascular dementia and stroke. But the truth is, the rule is most patients with dementia actually have mixed disease. And I think embracing that complexity and looking at the role of the blood vessels in neurodegeneration, even prototypical neurodegenerative disorders like Alzheimer's disease, is really important. But I'm going to start by talking about intracerebral hemorrhage because I think there's some opportunities there. So you can get my slide deck to speak to me. So this is the other kind of stroke. This is the red-headed stepchild. Most of the attention is paid to ischemic strokes, and understandably so, because we've had exciting breakthroughs in how we handle ischemic stroke, and I think it drives a lot of optimism in the field of vascular neurology. Whereas intracerebral hemorrhage is sort of met with a sense of fatalism that we used to see about ischemic stroke, and I'm hopeful that in the next decade we're going to see the same sorts of major breakthroughs in how we treat intracerebral hemorrhage. Even though this is the minority cause of stroke, about 15% of strokes are intracerebral hemorrhages. It accounts for about half of stroke-related mortality. These are very high morbidity lesions. 2.8 million deaths worldwide are due to intracerebral hemorrhage each year, and typically patients affected by intracerebral hemorrhage are younger than those who are affected by intracerebral stroke. Typically, when I talk about this, we're talking about intraparenchymal non-traumatic lesions, and when I talk about intracerebral hemorrhages from this point on, I'm not referring to subdurals, epidurals, and subarachnoids. Those are obviously important subclasses of this disorder. This also drives a lot of health disparity. Different ethnic groups are affected differentially. In the United States, the rate of intracerebral hemorrhage among African Americans is nearly twice that of Caucasian Americans. And globally, we see intracerebral hemorrhages at a higher rate among certain Asian populations than anywhere else in the world. It also affects low-income countries disproportionately, and this is primarily driven by undertreated hypertension. So the other really important takeaway is that this is about blood pressure control. And everything else I show you today pales in comparison to this. As we're treating and confronting intracerebral hemorrhage, we have to think blood pressure, blood pressure, blood pressure. Regardless of the cause of the hemorrhage, the problem is blood pressure. It means that this disorder is preventable. This really remarkable study, the InterStroke trial, assembled over 25,000 patients from 6 continents, trying to understand risk factors for intracerebral hemorrhage and ischemic stroke. And they found that a staggering 87% of the population attributable risk for intracerebral hemorrhage was due to modifiable factors. And far and away, the biggest driver on every single continent was blood pressure. So I want you to see this as a preventable disorder and something we can definitely do a great deal about. I'm going to skip over these couple and talk about mechanisms, because I think that moving from supportive care and the steps that we take in the neuro-ICU and the ER to try to control this to a really directed therapy has a lot to do with understanding the underlying mechanisms of hemorrhage. And the two most common are hypertension and cerebral amyloid angiopathy. Hypertensive ICH is usually the result of chronic microvascular changes rather than acute hypertensive event. So this has to do with chronic remodeling of small penetrating blood vessels. And you can see the typical sites are in the putamen and the lentiform nucleus. And you have these long, delicate, narrow blood vessels that become distended in what has traditionally been called a Charcot-Bouchard aneurysm. And I've got a beautiful pathological image of one of these aneurysms that prototypically forms in the setting of a hypertensive ICH. These are microscopic aneurysms. They're hard, if not impossible, to see on conventional imaging techniques. And again, they tend to like the basal ganglia, thalamus, cerebellum, and pons. Patients who present with hemorrhage due to hypertensive etiology are prone to hemorrhage expansion. And frustratingly, while most of us can recognize hypertensive intracerebral hemorrhage, there isn't really a beautiful gold standard for proving the point that this is due to a hypertensive etiology. In my own practice, I think that the diagnosis is strengthened by the presence of other signs of end organ damage due to hypertension. That includes white matter disease and a pattern of microhemorrhages that's typical of chronic hypertension. And then also systemic signs of end organ damage. So we look very carefully for remodeling of the heart, changes in the retina, and renal disease, including proteinuria. The presence of these things strengthens the notion that the hemorrhage was due to hypertension. And then I think most importantly, patients should log their blood pressure at home on a longitudinal basis. And the documentation of elevated blood pressure on home blood pressure logs is probably the most important part of this process. Cerebral amyloid angiopathy is the second most common cause and is a typical cause of lobar intracerebral hemorrhage, particularly among the elderly. And by that, we mean it's quite rare before age 55. And we really start to see a significant number of cases after age 65. This is due to the deposition of beta amyloid protein in the wall of the cerebral blood vessels, typically arterioles and small leptomeningeal arteries. Beta amyloid is selectively toxic for vascular smooth muscle. And we think this is mediated by activating the late complement cascades and causing lysis of the vascular smooth muscle. And consequently, it impairs autoregulation, making it so that the brain is no longer able to fine-tune blood flow to various parts of the brain, and it makes the vessels very brittle. Neuropathologically, you see concentric dilation in contrast to the Charcot-Bouchard aneurysms, and I've got pictures of this concentric dilation of vessels here leading to a microhemorrhage on this side. And typically, again, this occurs in the lobes of the brain. That's where beta amyloid is made. But I think it's important that half of lobar hemorrhages are not associated with CAA. Still the most common cause of hemorrhage is hypertension. So the location alone does not establish a diagnosis. And even though hypertension is not the major driver of hemorrhage in this disease, it is the most important modifiable risk factor. So aggressive blood pressure control remains the mainstay of preventative treatment among these patients. And then there's coagulation associated intracerebral hemorrhage, which we see a great deal of. It's not actually clear if the blood thinners themselves are the cause of the hemorrhage or if they simply interact with other existing risk factors and worsen the intracerebral hemorrhage. Certainly the latter is likely true. The degree of elevation in PTT or INR when patients are on agents that prolong the PTT is associated with the degree of the risk. And these, more than almost any other intracerebral hemorrhage, are prone to hemorrhage expansion. And just one clinical pearl on these: if you see a fluid level in the acute intracerebral hemorrhage, you should think of a coagulopathy, either acquired or a therapeutic coagulopathy in these patients. This is a fairly specific but not sensitive marker of the presence of a coagulopathy. And then there are a range of secondary causes of intracerebral hemorrhage, and we think of them typically as being tumors, vascular malformations, and septic emboli. And I'm not going to spend a great deal of time here to try to preserve time for other things, but it's important when tumors look, or when hemorrhages look a little bit funny, to think about these secondary causes, because many of them will dramatically alter how we treat patients. For the diagnosis of the underlying vasculopathy, In the acute phase, primarily relies on obtaining high quality neuroimaging if it's available. And we focus on the presence of white matter hyperintensities in large perivascular spaces. And what I'm going to talk to you more about than anything else is the presence of cerebral microhemorrhages. And I'm just going to make one comment on enlarged perivascular spaces, because we used to sort of dismiss these as being clinically silent. That we've observed them for a long period of time, but emerging literature, including the work of Angela Jefferson and some of our colleagues here, has shown a fairly strong correlation between the presence of perivascular spaces, in particular places, in particular the basal ganglia, and the progression of cognitive symptoms among patients with early stages of cognitive impairment. And you can see this typical pattern of enlarged perivascular spaces in the basal ganglia. If you look at this on an axial format, you'll actually see them in a linear pattern. These perivascular spaces can, on occasion, become very, very large, what we call tumefactive enlarged perivascular spaces. And even when they're that impressive, patients are usually doing just fine. The other thing to note about them is that there had been this notion in the literature for many decades that these perivascular spaces were artifacts from fixation. But I like to show this sample of an unfixed piece of human brain from one of our brain donors who had cerebral amyloid angiopathy. You can see a little microhemorrhage here, and you can see that the perivascular spaces are obviously there before fixation, and other people have documented this very nicely. So I want to spend a couple of minutes on how to interpret microbleeds in the brain. We see them a lot, and there's a lot more to the usefulness of this as a biomarker than just are they there or not. Very often we get a report that the patient has multiple cerebral microbleeds, and it could mean hypertension or CAA or a number of other things. And the pattern of these lesions can be very, very helpful in diagnosing the underlying microvasculopathy. So what I've shown you in this set of images is a prototypical case of severe cerebral amyloidangiopathy, where the hemorrhages cluster at the gray-white junction, primarily affecting the cortex, sparing the deep white matter tract, sparing the basal ganglia, the pons. Generally, this also spares the cerebellum, but not always. And it is a typical pattern in cerebral amyloid angiopathy. We went to the trouble of doing postmortem imaging and cutting a few of these out of the brain to confirm that, in fact, they are hemorrhages. And I can confirm for you that the vast majority of them reflect hemorrhages in various stages of healing. When we look at these up close and personal, it's interesting that the spot that we see on the MRI is often quite a bit larger than the corresponding hemorrhage. And this has been termed a blooming artifact. And this led us to try to study the physics of this a little bit and understand exactly how much iron is in these lesions and see if we could extract more information. In the interest of time, I'm not going to go through the physics in a great deal, except to tell you that what you are looking at when you look at a susceptibility weighted image or gradient echo image is actually the dipole, the magnetic artifact around the hemorrhage. And so it's actually larger than the hemorrhage itself. It is proportional to the mass of iron that's present, but it's not a linear relationship. And so here I've charted out the blooming effect, the size of the actual lesion versus the size of the hypointensity that we see on the MRI. And you'll see that consistently it's overestimated. And this overestimation of the size of the lesion is more dramatic as you approach the voxel size. So the smaller lesions, the larger the relative blooming effect. Most lesions represent between 1 and 12 micrograms of iron. And the average concentration of iron is about 2 milligrams per gram of tissue, and just 3 or 4 times the concentration of iron in the blood, which I suppose is to be expected, because as the hemorrhage heals, the iron is concentrated into that lesion. A couple other things to note. One is that gradient echo T2 star images are typically less sensitive for the detection of intracerebral hemorrhage. And here we've marched out the microhemorrhages you can see in matched pairs of gradient echo and susceptibility weighted imaging based on the size of the hypointensity that we're looking at. And you'll see that they're fairly good at detecting lesions as they pass 2 to 3 millimeters in diameter. But gradient echo misses a lot of these smaller lesions. This is important partly because of the differential diagnosis of microhemorrhages. In cerebral amyloid angiopathy and infective endocarditis, this peak that is more or less missed by gradient echo is the size of the most typical lesion in CAA and in infective endocarditis, whereas hypertensive lesions tend to be a little bit bigger and they're detected more reliably on gradient echo. So we favor susceptibility weighted imaging. You can often make a decent diagnosis with gradient echo T2 star, but be aware that you're probably missing some portion of the microhemorrhages. And I want to put these images up right next to each other. These are typical images from a patient with cerebral amyloid angiopathy on top and patients with hypertension, severe hypertension on the bottom. And what I want you to see is that there's this relative size differential between the microhemorrhages. And we don't talk much about that, but it's actually statistically one of the strongest findings we've ever had. The p-value is something like 10 to the negative 32. These are definitely bigger. They're millimeter, but importantly bigger. They cluster in the basal ganglia and in the cerebellum. They often involve the pons and midbrain, which is not involved in this case. And notice that those sites are generally spared in cerebral amyloid angiopathy. There's a few other causes, and Brian and I, in our time at Yale, worked on infective endocarditis and defining the distribution there. And here we found that the distribution basically fit a proportional model distribution. So as you would expect from lesions that were originating from the heart, they more or less landed in a random distribution in the brain involving the white matter, involving the deep and the cortical structures. There was a slight preference for the posterior circulation beyond what we model based on a random distribution. But endocarditis can definitely cause microbleeds as well. So here's the differential diagnosis. Typically, these top three are the ones that we spend the most time thinking about, but trauma can definitely do it. Aortic dissection and valve replacement will have a pattern similar to infective endocarditis, and most patients who have had these events happen to them have a few cerebral microhemorrhages. Radiation vasculopathy, typically after whole brain irradiation, patients get innumerable microhemorrhages, usually about a year to 2 years after the irradiation, and that continues to progress as long as the patients are alive. Cerebral fat embolism will cause more microhemorrhages than almost anything else. They're very, very tiny and will be almost completely missed by gradient echo T2 star. So you'll want to look with susceptibility weighted imaging. And I'm going to skip over superficial siderosis. This is similar. It's just related to oozing of the blood into the subarachnoid space. So it's bleeding from a slightly larger artery, and it suggests higher severity of the degree of cerebral amyloid angiopathy. So it's a secondary hemorrhagic marker of CAA. And this has led to some codification of the diagnostic process for cerebral amyloid angiopathy, which we call the Boston criteria. The Boston criteria, I think, are really only useful in this category, the probable CAA category. So when I tell you that a patient has CAA, in most cases, this is what I mean, is this probable category. Patients are in the right general age. They have more than one cerebral microbleed in a pattern that's typical of CAA, and there's an absence of other causes. Possible CAA, this category has not verified to a high enough degree of accuracy to be useful. And these other two categories require autopsy or biopsy, which are, again, not practical. So for me, this is what a clinical diagnosis of CAA means. At least 2 microbleeds in an appropriate distribution in a patient who's over 55. So as I'm leaving behind the more clinical part of the talk, I want to flash up these various causes of intracerebral hemorrhage, because I think that it's a useful pearl to sort of cement these patterns in your mind. Hypertensive related bleeds tend to be deep. They tend to have a pattern of microhemorrhages, which can involve the lobes, but should not spare the deep structures of the brain, and the microbleeds are a little bit larger. CAA tends to be peripherally located with a pattern of microbleeds that's supportive, that has a lobar predominance. Coagulopathy related hemorrhages are prone to expansion. So these images were taken 3 hours apart, and you can see that the hemorrhage is expanded, and there's a fluid level, which is not always present, but when it is present, it is a fairly specific indicator of a coagulopathy. When you see mixed ischemic and hemorrhagic pathology, and the hemorrhages are in a cardioembolic pattern, think septic embolism. This is infective endocarditis. When you see edema out of proportion to the size of the hemorrhage, think tumor. This is a small metastasis epidermis of melanoma. And here I've flipped the images. This was actually obtained prior to the presence of the hemorrhage, but it made for a better image. And then finally, think vascular malformations when you see patients who come in with lesions with less severe symptoms than you would expect for the lesion that they have. This patient should be in very, very bad shape with a hemorrhage in this location, but walked into the hospital with a hemorrhage. When that happens, think vascular malformation. This is a cavernous malformation, and this is oozing of blood from non-arterial flow, and so it's a less catastrophic insult. It's a good pattern to keep in mind. Understanding the underlying etiology is key to effective treatment of intracerebral hemorrhage. So I want to spend the rest of my time talking about cerebral amyloid angiopathy and trying to get you folks up close and personal with this pathology, because I think it's an interesting topic and it's not rare, and it's something that complicates the treatment of a lot of other diseases, including Alzheimer's disease. We're paying a lot of attention to this because the ARIA-E complications that are emerging from the anti-amyloid therapies are accelerated cerebral amyloid angiopathy. So I think the first caveat to this is that cerebral amyloid angiopathy is not the same as any other systemic amyloidosis. And in fact, they're not particularly closely related diseases. So this is driven by the beta amyloid peptide, which is the beta amyloid that causes the plaques in Alzheimer's disease. And these other forms of amyloid don't cause similar changes in the brain with any regularity. So as I mentioned earlier, CAA contributes to roughly 50% of lobar hemorrhages, particularly among the elderly. After the first hemorrhage, the recurrent rates is substantial. So the average patient has a recurrence every 7 years or so. This risk is compounded by the presence of hypertension and anticoagulation. We meet patients with CAA, half of them through the ICU with a hemorrhage and about half of them with cognitive impairment through the memory clinic. It's present in something like 80% of cases of patients with Alzheimer's disease, but it's really the moderate and severe forms of CAA that are pathological, and that's probably 25% or so of patients with CAA. It independently contributes to cognitive impairment. So CAA by itself can cause cognitive impairment, and it certainly interacts with other neurodegenerative processes. The prototypical cognitive symptom in this case is cognitive slowing. The patients have this slowing of processing speed. And the microhemorrhagic changes that I'm showing you probably contribute to a small degree to the overall cognitive symptoms, but they're not a major driver of cognition. But they are useful as a biomarker, and they predict subsequent conversion of mild cognitive impairment to full-blown dementia. So it is a useful clinical variable. Patients can also present a third way, and that's with amyloid spells, which are often interpreted acutely as transient ischemic attacks. So it's important to have this in the back of your mind, because we would treat this totally differently than we would treat TIA. We've had this story a lot where patients come in with what is thought to be a TIA and are put on antiplatelet therapies or anticoagulants and then come back with a hemorrhage. And so just having in the back of your mind that amyloid spells are out there can be useful to try to avoid that. They can range from migrating sensory phenomenon, which is probably the most prototypical amyloid spell, to staring spells, to focal motor seizures. Some of these are very clearly epileptiform, although there's some debate in the field about how many of these spells are epileptiform versus other phenomena. So this is incompletely studied, but it definitely is a factor. It very closely correlates with the presence of superficial siderosis on the MRI. And it's probably a marker, again, of disease severity. We see amyloid spells in patients with more severe disease. Here at the right, I have the first published images of cerebral amyloid angiopathy. I forget how old this was. It was in the first half of the 20th century that these images were published. And this is an old-fashioned Congo red stain, which is still used in the path department from time to time. All right, and then there's a final version of CAA called inflammatory CAA. And it's got a lot of other equivalent terms in the literature. And I think importantly, ARIA-E, the side effect that we're seeing from anti-amyloid therapies, is very likely this disease state. And this is where you superimpose on top of cerebral amyloid angiopathy, vasculitis, a peripheral autoimmune response. And so in addition to the typical findings of cerebral amyloid angiopathy, we see brain edema. We tend to see more microhemorrhages. We see swelling. And it's important to recognize this because it presents with rapidly progressive symptoms, and it is in most cases treatable. These patients tend to be exquisitely sensitive to corticosteroids and sometimes more aggressive measures like cyclophosphamide or Cellceptor needed. And what we see pathologically is this severe perivascular infiltration of T cells. It looks something like this. It can be unifocal or it can be multifocal, as in this case, cerebral edema. Accompanied by, again, this vascular destructive inflammatory reaction. You can see in this case, the structure of this vessel has been completely undermined. And so the patients go on to get numerous cerebral microhemorrhages. Really important to recognize because it's treatable. And I think that's all I'm going to say about that. The genetics of CAA have some interesting things to contribute to our understanding of the disease. Sporadic CAA, like Alzheimer's disease, is closely associated with the E4 allele of ApoE. It tends to drive a more vascular phenotype of Alzheimer's disease. And there's one fairly good correlate, one SNP and a complement receptor, which is also linked to the risk for cerebral amyloid angiopathy. And I think that's interesting because we do see fairly extensive late complement activation on the vessels. There's a number of autosomal dominant mutations that can drive a hereditary aggressive form of this disease, most famously CISATN-C among an Icelandic population of patients, and an APP mutation in Dutch kindred. These are very rare disorders, but they tend to affect patients at younger ages, in their 40s and 50s. And it's also interesting to point out that some hereditary prion diseases also cause cerebral amyloid angiopathy, and that's what I'm showing you here. This is the so-called apple green birefringence that comes from Congo red staining. I'll tell you the truth, I never really thought it was that apple green. It's sort of this glinty gold color. But if you ever get a chance to see this under polarized light, it really is quite pretty in real life. The neuropathology is interesting. In the old days, this was looked at with a silver stain, which is more or less gone away now, although people still do silver stains occasionally. Silver stains are useful because they'll show the presence of plaques, tangles, and cerebral amyloid angiopathy. I mentioned Congo red, which is causes that birefringent light pattern under polarized light. The thioflavin is a fluorescent molecule, and it's a turn-on probe for beta amyloid. So when it binds to amyloid structures, which will in most cases be both plaques and tangles, the fluorescence of the marker goes up about 20-fold, which is very nice. It causes a very good signal to noise. And the reason I'm mentioning thioflavin to you is that it was the parent compound for Pittsburgh compound B, which was developed into the PET ligands for amyloid beta. And so it's been a very important compound for improving our diagnostic approach to Alzheimer's disease. And we have derivatives of these molecules that are useful in the stainings that I'm going to show you next. So methoxyXO4 and thiazine red are related to Congo red and thioflavin, and they're more modern versions of these. And I'm going to use them in the images that I show you next. So I want to get you up close and personal with this pathology. Here is a set of stainings, and you can see that the beta amyloid stained in blue coats the vessels in these organized rings. And within these little hollows in the beta amyloid is where a vascular smooth muscle cell is or used to be. If I flip forward here, we've stained the vascular smooth muscle here, and you can see that a few of them survive, but pretty quickly these become hollow and brittle. And these organized rings, as the vessel deteriorates, shatter and turn into these shards. And so this is what happens as a vessel hemorrhages. The vessel dilates concentrically, and the amyloid beta that was previously organized becomes disorganized and sharply contoured. And here it is in 3 dimensions, showing you a vessel that is ruptured. And here again, you can see the shards of beta amyloid stained in red that survive in this badly distorted vessel with an exploded edge. So what we found in the last few years is that the vessels that are affected by CAA are dramatically stiffer than normal vessels. So here we have atomic force microscopy among patients with Alzheimer's disease and controls, and they have about patients with CAA have about a 4-fold increase in the degree of stiffness of the vessels. And we found two major drivers of this. One is an enzyme called Lysol oxidase. This is an enzyme that cross-links extracellular matrix proteins and stiffens the connective tissue matrix of blood vessels. And when we see vessels deteriorate, we see a lot of Lysol oxidase deposition, including these very expanded blood vessels here. You can see Lysol oxidase stained in red here. We also notice clusters of cells in the subcortical white matter here that are positive for Lysol oxidase. The other thing that we've discovered, and I'm going to talk less about today, is that there's a pattern of myelofibrosis. We see a grouping of fibroblasts on the surface of the connective tissue of the blood vessels that stains for vascular smooth muscle markers, which can lead to stiffening of the vessels. So I'm going to primarily talk about Lysol oxidase for the next couple of minutes as we close. And try to convince you that this might be an interesting target. So we find this interesting for a couple of reasons. One is we see it on the blood vessels that are affected by CAA. Here again, it's stained in red and the amyloid is in blue, but it's also in plaque. So here's a patient with Alzheimer's disease without cerebral amyloidangiopathy, a more normal looking blood vessel here. And you can see in the blue plaques, the core of the plaque has intensive immunoreactivity for Lysol oxidase. So it's in two very interesting locations, which make it potentially a multifunctional drug target. Let me show it to you in some blood vessels here. So here's a relatively structurally preserved vessel with fairly heavy amyloid deposition. Amyloid is stained in red, and you can see that vascular smooth muscle, amyloid's in blue in this case rather, the vascular smooth muscle is stained in red, and you can see where there's amyloid, there isn't a lot of vascular smooth muscle. And then Lysol oxidase in the most severely affected portions is stained in purple right here. And you can see as the vessel becomes more structurally destabilized, you get these more dramatic deposits, again, in this pinkish purpley color of Lysol oxidase. And they correlate with this blue signal for the amyloid deposition. So this is a badly distorted, degenerating arteriole. And we're seeing that on this interior curvature of the vessel, which remember, this should be a long, straight, delicate vessel. So this distortion is pathologic. And the LOX deposition is heaviest where we see those twists and turns and dilations in the vessel. We also noticed that clustering of cells in the subcortical white matter, and I'm showing it to you here. We discovered that these were clusters of astrocytes, which also seem to secrete an intensive amount of LOX. So here's GFAP, an astrocytic marker, and I'm showing you the Lysol oxidase staining on top of these astrocytes. And you can see these LOX-positive astrocytes here reaching out to the blood vessels and having these end-feet contacts with the vasculature in the subcortical white matter. We think that this is probably the source of LOX in the brain. And the reason we think that is a couple of things. I'm going to skip over this part. The reason we think that is because when we look at the expression pattern in induced pluripotent stem cells, we see small amounts of LOX expressed in endothelial cells and vascular smooth muscle cells, but we see this dramatic amount expressed in astrocytes. And when we expose the cells to inflammatory stimuli like TNF-alpha, we get this increase in LOX expression, both in astrocytes and endothelial cells, but the degree of expression in astrocytes is just orders of magnitude higher. And importantly, when we look at the brain tissue from human donors, we see a dramatic increase in the amount of LOX that's present in the white matter from these tissues. So we think there's a great increase in the amount of LOX, and that this is a secreted protein. And so even though it's made in these subcortical astrocytes, it will be able to migrate in the perivascular fluid flows and affect the cortical arterioles. So we think that's probably the source. The biggest problem for moving forward with targeting this molecule as a vascular conditioning agent is that we don't have a great mouse model yet. So this is one of the major issues that we've been working on, is trying to model cerebral amyloid angiopathy better in mice. The currently available models don't develop those organized concentric dense rings of beta amyloid. They don't involve the leptomeninges very much. So what we've taken to doing is purifying beta amyloid seed material from human cases and taking these seeds and administering them to the ventricles of mice that carry pro-amyloidogenic mutations. And by doing that, over the coming 3 to 4 months, a substantial portion of the beta amyloid is moved from the parenchyma to the vasculature. We end up with heavy deposits of cerebral amyloidangiopathy on the vasculature. We're still working to fully study this this mouse, but I think that what's our most promising marker so far is the physiology of cerebral blood flow autoregulation. When we look at a normal mouse, you can see the blood flow in the brain. When we stimulate the animal, we get this increase in blood flow. We don't see the same pattern in our model mice. When we stimulate the animal, we see large swaths of the brain that just don't respond to that stimulus in the same way. And so we see about a 50% reduction in the ability to autoregulate blood flow in this little model mouse. And in static numbers, it looks like this. We do see a slight decrease in the resting blood flow as well, as you would expect with an arterial or pathology. But it's the ability to auto-regulate that's most compellingly decreased in these little mice. So we're hoping that this is going to give us an in vivo model to test LOX inhibition and hopefully carry this forward into a drug discovery platform. So in terms of thinking through what we're going to do next, we're fairly confident that the source of LOX in the brain is these astrocytes, but we have to go on and confirm that and understand the contribution of endothelial cells and smooth muscle in a clearer way. Most of the drivers of LOX expression and activity that have been reported in peripheral studies of LOX we're seeing are still relevant in the brain. We're working through that, and I've skipped over some of those pieces of the story in the interest of time. It is interesting that LOX is activated by apolipoprotein E, which is a major driver of Alzheimer's disease, but we haven't studied yet the effects of the E4 allele on LOX activity. And so that's one of our priorities in the near future. But I think one of the key things is we're working to develop a set of blocking peptides that we can use to scavenge LOX from the brain in an isoform selective way. And we want to use this in the new mouse model. So I've brought a handful of other things, but I think it's useful to pause for a few questions and have a chance to talk about some of the things we've shown you. So I just want to thank my team. Wilbur is a staff scientist with us who's done most of the molecular biology, and those beautiful three-dimensional images were done by Lisa Ventura Tunez, and Elaine is my lab manager who keeps the wheels on the bus. So I'll pause there and take any questions if people have questions.
Thank you, Matthew. So I will help mediate. People have questions. Joel, do you want to go first?
Yeah, I was just wondering, that was a great talk. Thank you so much. I was just wondering why, if there's co-pathology between AD and CAA, why we don't see more lobar hemorrhages in our Alzheimer patients.
You know, so we do see some. I think statistically that patients are at higher risk of having a hemorrhage. But I think when we systematically screen for CAA, we're seeing extensive microhemorrhages in about 25 or 30% of those patients. And there is some debate about whether there's multiple phenotypes of CAA and whether there's a phenotype that's less prone to symptomatic hemorrhages and more to cognitive symptoms. But I don't know that there's a great mechanistic explanation yet for why that happens. My own view is that you're probably looking at the interaction of other risk factors. And so if they don't have hypertension or other risk factors, the odds of them having hemorrhages are a little bit lower.
Okay, thank you. Cristobal, don't recognize the name.
Yes, hi, I'm Cristobal, and I'm actually from the DSMN program. So I'm actually a graduate student at Charlotte Roglu's lab, and we study astrocytes. So I was just wondering about your story on how LOX and the astrocytes are. Do you think that first and foremost, like, do astrocytes always secrete LOX, or do you think it's only, like, the diseased astrocytes that secrete LOX? And if so, do you think there's any thoughts on whether it's the A1 or A2 reactive astrocytes?
Yeah, we're actively working through that. No, they do not all secrete LOX. And so I skipped over this, but it's actually an interesting result. We're working on postmortem MRI study to try to understand what types of astrocytes secrete this, and some of it is anatomic. When we look at these postmortem images, we're looking at the white matter hyperintensity. We had observed rafts of these cells. So it's patchy, it's not everywhere in the white matter. And what we found on the postmortem MRI work is that it correlates with the presence of these white matter hyperintensities, that we're seeing about a 10-fold increase in the number of LOX positive astrocytes in areas that have hyperintensities versus same case control areas that don't have hyperintensities. We see that we think most of the LOX positive astrocytes are in an activated morphology, but we haven't been able to get subtyping yet. It's on our short-term agenda to answer that question, because I do think that's important. It's certainly a minority of astrocytes, a few percent of the total astrocytes that are LOX positive.
Nada?
Hi, thank you for the talk. My question is, as you mentioned, there is a higher prevalence of microbleeds in patients who have had cardiac valve replacement. Do you have any theory about that?
Yeah,
Like,
I think so. I mean,
pathophysiology?
we say very confidently what causes this, and the truth is I don't know that we know. But the cholesterol emboli are very sharp crystalline structures, and so we assume that the embolism of these sharp cholesterol crystals is enough to puncture the fine capillaries in the watershed capillary beds. We don't have any evidence that they increase the patient's long-term hemorrhage risk. And so if they're attributed to valve replacement or aortic dissection, we've not typically prescribed anticoagulant or antiplatelet therapies in that population.
Thank you. Swaroop?
Oh, yes. Thank you so much for this wonderful talk. Question I have is more clinical. You did mention about Tiffany's that can be seen in patients with CAA versus TIA. The imaging findings for most of these patients do have an overall, meaning patients do have cerebral microbleeds as well as small vessel ischemia. It can be difficult to challenge or depict what actually happened. Is this an ischemic insult? Could this be a Tiffany? The treatment options are variable. For TIA episodes, you might subject patients to DAPT, whereas with Tiffany's, you don't want them to be on antiplatelets. How do you distinguish? That can be a challenge. And what are your treatment strategies when you come across something similar on imaging and clinically?
And I'd say thank you for that question too.
Yeah, that's a great question. So I'll tell you that clinically, there are some differences. One is that the TFNEs, the transient focal neurological episodes, or amyloid spells, tend to not have that maximal onset pattern that we see with embolic strokes. And so I think that really carefully reviewing the symptoms can be helpful. They tend to have creeping sensory changes. They tend to have an aura. They tend to feel a little bit more like cortical spreading depression. So carefully reviewing the symptoms is helpful. I think when in doubt, getting screening and looking for superficial siderosis, there is really a close relationship between TFNEs and superficial siderosis. And so I think that can also be helpful. But I think that if you pay attention to the distribution of the microhemorrhages, the patterns, if patients have microhemorrhages in a CAA pattern, think TFNE. It's more likely.
I see. Thank you so much.
Brian, do you have a closing comment or question?
I do have one question, actually. So I had a patient in clinic a couple of weeks ago who presents with 2 years of gradually worsening cognitive impairment. And also then the reason she came to see me was because she had a lobar hemorrhage. She's got cortical microinfarcts, superficial siderosis, and a posterior predominant flare changes. But she doesn't have a single cerebral microhemorrhage, despite SWI imaging. And I'm wondering, can that person still have CAA if there's no microhemorrhages, but almost all of the other clinical or imaging features?
Yeah, frustratingly, the answer is yes, they can. the image, so you'll see a discrepancy between the pathology literature and the imaging literature regarding the prevalence of CAA, and that's because the neuropathologists are looking at much lower degrees of CAA. So what we're seeing clinically when we're seeing microhemorrhages really correlates to moderate and severe CAA pathologically, and that explains that discrepancy. But there is certainly a degree of CAA that is below the detection threshold of an MRI. You can get at it by looking for the presence of beta amyloid in the CSF. So we can do screening that way. But again, it's not specific. It simply tells you that the patient has beta amyloid pathology and doesn't necessarily confirm that it's primarily vascular. But I think more than anything, the key is to rule out and manage other processes that may be contributing. Yeah, it can be tricky.
Understood. Thanks very much,
Matthew, I'll take the prerogative to do kind of like a final Jeopardy with you, and I want to ask you 3 questions, and I want less than 5-word answers.
Okay.
All right. Asymptomatic microhemorrhages and TPA.
In a CAA pattern, no.
None.
None.
So you won't give TPA.
Not when they're in the CAA pattern, not when it's convincing. So let's say there's 5 or more microhemorrhages, I would not.
Okay, great. All right. White matter changes on the MRI of someone with dementia, vascular or not?
Likely vascular, not necessarily CAA.
Wrong answer. Okay, that's number 2. Number 3 is why do some people get CAA and others don't, even though they all have a similar underlying disease?
I would really like to get at that question. I suspect it's genetic. We certainly see the ApoE alleles seem to drive a more vascular phenotype of Alzheimer's disease, and I suspect that there's other genetic drivers, and I suspect that there's some lifestyle drivers too. But we don't have a compelling answer to that question, and I think that we would learn a lot by trying to answer that question.
Right.
That's more than 5 words.
Wasn't a 5-word question, but anyway, thank you so much. Brian, thank you for bringing Matthew. And to everyone else out there, stay safe, and we'll see you next week.
Thank you.